Good morning. I realize that I'm just between you and a break, a cup of coffee, so I'm going to try to be quick about this, because we all need a cup of coffee. So previous years I've talked more specifically about a particular intervention, so I sort of feel set up to talk about the joint engagement work, but I won't talk a lot about it. I'm going to give you just a flavor of some of the research. And actually, I didn't change the order of my slides, so you'll be able to follow along just fine, I think. For today's talk, I want to talk a little bit about some of the promises that we've learned from the intervention work that we've done. So we've learned a lot about what the active ingredients of behavioral interventions are, really the factors that matter, and so why the intervention really works. And we keep doing research to sort of chip away at these issues, because it's not so important that we have a comprehensive package of an intervention unless we've tested all of the different components. So we need to know what those active ingredients are. And we've, since Marion's early work in the late 70s, early 80s, we've been also very much focused on what are the core features of kids with autism. And you've heard about that this morning from both Ted and Shefali. So we want to know what's specific about autism, not just about the developmental delay, and also recognizing that much of the kids' behavior is just very typical. We want to figure out what is the autism-specific pieces that we can address in interventions. And also recognizing that some of those features of autism we don't actually need to change with intervention, that some things are just fine. It's only the parts that are very interfering or long-lasting effects, which you heard about this morning. I also want to talk about some of the challenges of moving these interventions into the community, and so that's the piece that we've been working on more recently. And really into the schools has been a huge challenge for us, but a really exciting one. And so I'll talk a little bit about that work. Another challenge is just bringing those interventions to scale, which is what we're going to be doing, hopefully. So when we talk about active ingredients, there's a lot of different ingredients that we could address. One of those has to be the approach, and that's probably what most of you have any experience with. So you hear a lot about ABA is the most common, the only evidence-based approach, and so people are very concerned with how you teach kids with autism, and ABA is just an approach. And there are many types of ABA interventions and many interpretations. We also talk about dose, so how many hours does a child need? So that's typically what people think about, right? 40 hours a week, 30 hours a week, 10 hours a week. How many hours does my child need? Well, I'm a little bit more concerned with the density of intervention. How dense is that intervention? So when you spend time in a treatment for an hour, do you have lots of opportunities to learn? So there's both intensity and density. And then people look at the agent of change. Should it be the parent? Should it be the teacher? Should it be the therapist? And there are lots of different opinions about that at different ages. And then the content. What is it that we're actually trying to teach children? And this comes back to those core deficits. And it's the piece that we've been very concerned about and the piece that hasn't had as much discussion in the literature. And then also the context of the treatment. Where is this treatment taking place? Is it in the lab? You know, we like to do things in the lab because we can control a lot of things. Or is it out in the community where we have less control? So today I'm going to talk mostly about content and context. So context, and I want to get right to where we're concerned about interventions, and that is in the schools. So kids spend the most time of their day in school. But there's been very limited evidence that school programs actually use the evidence base that's out there. They often use eclectic approaches. And so eclectic has sort of a bad term in the literature, but for me, eclectic is good. It means that it's informed, it's not random, if that's the way that it's happening. So in other words, you're taking the evidence-based components that work together. And so an eclectic approach can be very good. The problem is it's often random, right? So somebody wants something and so they say, okay, we're doing this or we're doing that, or there's pressures to put together components that could be just randomly selected, and so that's a problem. And I think schools are really pushed in that direction, and it's not their, I mean, they contribute to it, but it's certainly not their fault. They have a lot of outside pressures. And then for mainstream children, so these are the kids who can go into the regular classroom, sometimes interventions are completely absent, and so we're concerned about that. I'm also concerned that parents spend a lot of time in their day just driving their kids to therapies outside of school. You know, I mean, my kids played soccer and we spent a lot of time going to soccer practices and matches, but we didn't do that every day. And I think some parents are spending inordinate amounts of time and money having to take their children for tutoring. And it's often for things that they're just not getting in school. So that doesn't make sense to me. It seems to me that we ought to bring in the treatments that are necessary for children into the place where they spend the most time. But in order to do this, one of the conversations that's not happening is that we need to bring the general ed folks around the table. So every conference I go to, every meeting I go to, it's always great when there are some general ed teachers or administrators in the audience, but it's rare. So how many people out there are general ed people? So no one. So this is, you know, my point is that we need to make more of an attempt to bring those folks in. Okay, so conducting research in schools is not easy because schools have so many layers of complexity. They have state-mandated curricula that they have to do and testing. They have district or building level procedures. They have so many interruptions and pressures that aren't in any treatment manual. And there's a general suspicion about research and researchers and research in general. And that makes sense because, you know, it's the flavor of the month. You know, every few months there's a new thing that people want schools or teachers to do. And so they get a little jaded about the whole process. I think it's also important to remember, and this is some quotes from John Weiss, who's a very smart treatment researcher. The vast majority of children have never been tested in any outcome study. And of the many treatments that are available, only a fraction have ever been tested in research. So even though there are these sort of programs that have their disciples, most therapists, most teachers don't adhere to any one treatment, but they're going to create their own that's based on their own training, their own supervision, and their own experiences. So when we come in and say, okay, here's a comprehensive treatment and we want you to do this, so for some teachers, that's pretty upsetting because they know things that work for them and it may not be what you're suggesting, right? So they don't want to throw out all of their experiences, all of their knowledge to do something new that may or may not have been tested so well. So those are some of the issues. But as researchers, we also have our own sort of beliefs about how we should be doing treatment studies, right? So we love efficacy studies, which are in the lab studies where they're highly controlled. We select particular kinds of kids. We know if something works because we've controlled everything. And I would say the majority of autism intervention research is organized in that sort of fashion. We're starting to do what's called partial effectiveness studies, and that's where researchers are actually going into the natural setting. So they go into the home and work with the parents, or they go into the school. But still, the therapist is the one who's delivering the treatment. So that's why it's not completely an effectiveness study, which is where the researcher might train the school staff or the community therapist or whomever to actually deliver the treatment. And another point about effectiveness researchers is it's all comers. The same thing within school-based studies. All comers. So you have kids with comorbidities, you have kids that don't fit certain criteria. It makes it a lot more complicated for the researcher, but it's much more real world. And then the sort of final step that we haven't done yet in autism research is this idea of deployment. So it's where you have community partnered research methods, where the researcher actually partners with the school district or the teachers or the community therapists. And we, as researchers, might present what the evidence base is and the school will tell you what components will work and what their challenges are, what the barriers to implementing that intervention, what the incentives might be for implementing that intervention. And that's the phase where we're just beginning, and I'm really fortunate to have great partners in Los Angeles Unified School District who are very interested in bringing some more evidence-based practices into the schools. And so we're actually starting to partner and doing this whole process of thinking about how we can do this and how we can bring it to scale. And I think they're here today. I hope they're here. So, oh, they're here. Good. So Kara Gelfand and Debbie Moss. So we're excited about this. So issues that I think we need to consider to bring interventions to scale in schools are that we need these, what are called dismantling studies. We need to figure out the active ingredients. What's important to an intervention? We can leave out the things that aren't really working, that might just be fluff, that could be good if you wanted to do them, but aren't necessary for the outcomes. We don't always know that, so that's the part we need to figure out. If we can do that, then an active ingredient leads to a module. And teachers are more likely, and therapists, to implement a module as opposed to a whole comprehensive treatment. Another thing to consider is that we need to maybe stop doing so many lab-based studies. And I have a few, so I'm guilty. But we need to start in the place that we want the change to happen. So in the schools, in the home, wherever it is, just right from the beginning. So I want to talk a little bit about some of sort of my trajectory of sort of going from lab-based studies to partial effectiveness studies to effectiveness studies. So we've done little pieces of all of these, and I'll talk about some of those results pretty quickly. So as you heard this morning, I was sort of set up to talk about joint engagement, joint attention, and we think about engagement or joint engagement as really a critical intervention target for kids with autism, really across the lifespan. So when we think about those behavioral signs of engagement, some of what you heard about this morning is shared attention and affect between the child and another person. Joint attention, which I think you got a good definition from Ted this morning. I'm really interested in how you get children to initiate sharing, initiate joint attention, to be able to point to something to say, wow, do you see what I see, right? It's not so much the responding. We want them to respond as well, but we put them into situations where we're asking them to respond all the time. And they get to be pretty good at responding. They get so good at responding that when they come in to be tested at age 4, they sit at the table quietly waiting, not saying a word. Children don't do that. They're going to be saying, you know, what do I have to play with? What do I have to do? Our kids are put in this situation of just sitting there. So I'm not worried about the responding as much as I'm worried about them initiating something. Social play with others. So a lot of times we get focused on the skill development. Can they do this? Can they do that? But can they actually engage with another person? And then of course conversation as they get older. So the first example, and what I think you had reference to this morning, is this study that we did where we really focused on the core deficits. So all of the work coming out of the lab was suggesting that kids with autism, that are young kids, preschoolers, have this problem in joint attention. They're pretty good at requesting help. They'll take your hand to something, they'll point to something, but they don't often just look at you and an event as if to say, wow, do you see what I see? Or they don't come and show you something, right? So they don't engage in joint attention. So pointing to share, showing, symbolic play. And we developed an intervention module that really focuses on those core deficits that we call JASPER, joint attention, symbolic play, engagement, and regulation. And this model, the first study that we did, all the kids were in the same preschool program. They were in ECPHP before it, I mean, it was a long, long time ago. So it was an ABA-based 30-hour-a-week program. We saw 58 kids that were between 3 and 4, because back then that was really early for kids to come into the program. Now, of course, we see 2-year-olds or younger. And we randomly assigned kids to one of 3 conditions. We just left them in the program. They were getting, 30 hours of ABA, or we gave them 30 minutes every day of joint attention training or symbolic play training. So 3 different groups. And it was short. It was 6 weeks, but every day, so it was dense. And the goal here was not, a comprehensive treatment. It wasn't to do long-term treatment. It was to see if we could make a change in a very short period of time. So in fact, all of my studies are that way. They're short-term. Can we get a bump? Can we get a change? And we used expert therapists with those kids. So the theoretical goal here was if we could improve joint attention, we were going to get a change in language acquisition. That's what all the experimental studies had said. And in fact, that's what we found. But what was interesting is that both the joint attention and the play group, who both improved a lot in those 6 weeks in those skills that we taught, and the control group did not change. In terms of language, the bump was later. It was a year later. And so what we saw was that the kids in the experimental groups had 15 to 17 months language gain compared to about 7.5 months for kids who were just in ABA. And once they left the program, they were still getting a lot of hours of treatment. So it wasn't like it dropped off. The least amount was 20 hours, and some kids were getting 46 hours a week. And actually, the kids in the control group had significantly more hours of treatment after they left the program. And that could be for lots of reasons, right? So, but the point is that by putting in the content in those interventions, we got a change in language. We've now followed those kids up, and we saw them when they were 8 and 9 years of age, and we still have initiating joint attention as a significant predictor of language at age 9, and the treatment was still effective. So that's pretty interesting. But what we learned from that very first study was that these treatment protocols that you start with really evolve over time as you learn about them. We learned a little bit about active ingredients from that study, and it seemed to us that the mechanism, the reason that both treatments had the effect on language was that we were actually affecting joint engagement. So it was about keeping the child engaged while we brought in this content, and it was very developmental. We took kids from where they were. We didn't give them just skills because they needed those skills. We tried to figure out what they were ready to learn. We also learned what might not work. And so, the clinical, you get a statistical finding, and that's all well and good. You want to know, is there something clinical? Is it meaningful? So in all of my work, we keep trying to figure out what are those meaningful outcomes. A meaningful outcome for young kids is that they can engage with their parents or with their siblings, and that affects their language. Okay, so to bring those kinds of interventions into the school requires a lot of thinking about that. Because again, there are these challenges in the classroom environment. Teachers don't usually work one-on-one with kids, especially if the child's in a typical preschool. And if they do, they have to maintain focus on that one child within all these other distractions, and usually about 6 other kids going, Miss So-and-so, I need this or I need that, right? So how do you work one-on-one? And then collecting data is just not a preferred task of most teachers. So I want to give you 2 examples really quickly of how we've moved this into the preschool environment. So in the first study that we did, and this was done by Kathy Lawton, a graduate student of mine who's now an assistant professor at Ohio State, she actually taught teachers one-on-one to teach children one-on-one, okay, in the classroom. And she did it within 20 minutes, just 20-minute little bites of time. And what's interesting here is she taught them in the classroom one-on-one, but we measured the outcomes when the teacher was in the classroom with her whole class. And these were all preschoolers that were pretty high functioning, so they had some beginnings of language. And what she found was that there were, I think, 12 strategies that she taught the teachers. And of those, the teachers had evidence of 11 of those strategies. Is that right? No, 8 of those strategies that they used in the classroom. So when she compared the teachers that she taught versus the teachers she did not teach yet, so they were waiting to learn the intervention, she found that the teachers used the strategies she taught with all the kids in the class. And then on the particular child with autism, we found that that child significantly increased their initiating joint attention in the class. So I thought that was really exciting. To me, that was like a generalization. And Kathy said, no, 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 that's not a generalization. We taught them in the classroom. That's where you expect to see the change. And so that's great. I think that's right. And then in another study, Annette Kale in Norway actually wanted to teach preschool, nursery school teachers in Norway how to do this joint attention intervention, which she did. So she did a randomized controlled trial with 58 preschool teachers and 58 kids, and she got a replication of that first study so that there was more joint attention of the kids, and there was more joint engagement between the mother and the child. So just to show that, you know, you can do this in a natural environment and you can get replication of some findings. Oh my, I'm running out of time, aren't I? So buy-in is really critical, though, whenever you do these kinds of studies, whether you're working with a parent or you're working with teachers or whomever. And what we learned from the first teacher-based study was that it's really important to teach teachers the change process. What is it that you're going for? What is the outcome that you're trying to reach? It's not about do these skills in this particular order, because the next kid that they have is going to be very different from the last one they had. And so this heterogeneity is a huge issue. If you own, you know, we don't have to worry as much with parents, because parents typically will have just one child with autism, or they'll be their own, right? They're not going to see other people's kids that they have to intervene with. So with parents, you can teach them specifically to their own child. Teachers have to learn a broader set of processes. So I think that that was very important that we learned that, and it makes us think about how we intervene with teachers. And I think it's also important to establish where these strategies, which are really common sense, easy strategies, can be applied to all kids. That's not just about autism, it's about everybody. Okay, so I'm going to go quickly through a partial effectiveness trial that we did, where we actually thought about kids when they get into school and thinking about joint engagement. It's still a critical issue. We can get our kids doing pretty well on joint attention and play skills, but they go to school and now they're having problems with their peers on the playground, right? So even though they've done well in early intervention. So we did a school-based comparative efficacy study with 60 high-functioning kids with autism, 1st to 5th graders, 30 different schools, and mostly Los Angeles Unified. And we wanted to test very common interventions that are done. So one is to think about the agent of intervention. It could be a therapist going in and telling the child, oh, these are the issues that you need to work on, and let's work on entering into a game, let's work on conversation or whatever. Or it could be just taking 3 typical peers from the classroom and teaching them strategies on how to engage all kids on the playground who are isolated, having trouble, you know, whatever. The kids are very good at telling you who those kids are. And Steve Johnson's here, he started in this study. So you know that sometimes those kids nominate every other kid and not our kid with autism. And it's kind of a challenge to get around to our kid. But they will. So it's not just our kids that are having the difficult time on the playground. So we compared a child-assisted approach, which is the therapist working with the child, or a peer-mediated approach. Again, very short term, 6 weeks, twice a week, 12 sessions in a 20-minute chunks of time, because that's all you get in the school setting. And we did a 12-week follow-up. So what we found was overwhelmingly 1st to 5th graders, peer-mediated. Anytime you have the peers involved, you have a huge effect. That the child-assisted approach by itself was no different than the control group of just inclusion. So that actually was not what we hypothesized. And our primary outcome, again, looking for meaningful outcomes. So what's a meaningful outcome in this context? If I ask the parents, that would not be a meaningful change, because we're in the school context. And a lot of times parents can't even get into the school to see what's going on, right? So, and teachers also may not be a meaningful outcome because they're not on the playground. So a meaningful outcome for us is, what do the peers say? So we had the peers do a peer nomination measure in the classroom without ever identifying kids with autism. Who hangs out with whom on the playground? Who are your friends? Who do you like to play with? Who do you not like to play with? All right? So it's called a social network salience measure, and that was huge. So if you were involved with your peers, there was a significant change in the peer networks, and I'll show you what that looks like. And it maintained a follow-up, even though a lot of kids changed classes in a short-term follow-up. So this is the primary outcome measure. It's a map. You can see that there are a lot of kids' names there. So all the kids tell us who hangs out with whom, and we do some magic with some coding, so the kids don't know what this map looks like. And it's taking everybody's nominations together that you generate these maps. So you can tell, the numbers tell us how salient that group is, how popular that group is. The bottom kids in the blue are kids that are isolated. And by the way, neither of those have autism. And the little guy in red is a kid with autism. So he's connected, and he's connected in the way that we typically find kids with autism. He's just to one kid, or he's peripheral to a group. He's kind of hanging on. So over and over, we've done these studies now with using this methodology. Our kids are not the most isolated kids, but they are more often peripheral. So the goal of the treatment was to move those kids more into a centralized network of kids. So other findings from that study, which is, it's it's out now, so if you wanted to read it, was that the peer-mediated, kids who got a peer-mediated intervention, the number of kids that were nominating the child with autism as a friend increased over treatment, and it wasn't just the peer models, it was other kids in the classroom, so the peer models bring along other kids to nominate the child with autism. Our kids with autism were less isolated on the playground if they had a peer-mediated intervention. And even the teachers saw greater social skills, and they weren't always aware of which treatment the kids were in. But we had some concerns about kids, we were particularly concerned about kids who were doing well and trying to figure out who those kids were and how they did that, right? So about 20% of the kids in that study were socially connected to a group and had a reciprocal friend. So they said, you know, that kid was their friend and the same kid nominated them back. But they were not more engaged on the playground. So even being connected and even having a friend in your class did not translate to the playground environment, which suggests that the playground environment in general is a very difficult environment for our kids, and it requires a very specific intervention. And I've had a graduate student who's just finished a study on training aides on the playground to engage kids and to see what happens there. If you can train the aides to actually engage kids more, does it result in better outcomes? And the answer to that is yes, we can do that. It's very simple to do. It's probably the simplest kind of strategies that you can imagine, and it makes a difference. Another kind of interesting finding from that first study was that when kids had a one-on-one assistant, that they were less engaged on the playground, meaning they weren't engaged with their aide and they weren't engaged with other kids. So there's a problem, there's a disconnect between what we think we're doing with giving a child a shadow teacher and what's actually translating to the child's social development. And I think that's a piece we really need to think about. Okay, so the last part is thinking about deployment, and the idea is really to bring treatment research into practice settings early, not the last phase, to consider this sequential process. So a treatment that can work in everyday practice, you can assess the treatment outcomes in practice, and you can examine moderators and mediators in practice. So that's the goal of what we're trying to do now, and maybe in a year we'll have our first set of data trying to do this and we can talk about it. And I think some of the considerations that we're working on right now with our LAUSD partners are thinking about the practitioner concerns to their situations, their children, their family, right? Because that's their concern. Alliance and buy-in, how do they feel about us? Do they buy into what we're trying to suggest? And then really for us to really understand the context in which people are working. And so we're starting with focus groups, and I think we've identified 4 schools in completely different regions of Los Angeles, all very challenging environments, because LAUSD is 9% Caucasian, 75% of the kids I think are Latino, and 75 to 80% are free and reduced lunch. We have a really challenged population, and so we're interested in the schools that are under-resourced. We're not as worried about, of course now I'm starting to sound like Mitt Romney, not as concerned about those that have high resources in this case. Although those kids can also be underserved. Anyway. I don't think I have time, but I have little video clips of just one of the ways of involving school staff in very simple ways to keep kids engaged. So one of the issues is if you think that kids are isolated on the playground, well, how do you get them to go from class to playground and be engaged with a partner? There are lots of little strategies like that that are just, not brain science here. Sorry, I'm not doing brain science, Shivali. That are simple, that work. And so another little plug I'm going to put in, because I'm passionate about what I've just talked about, but I'm also really interested in these kids that we know less about, so low-income, underserved families, but also minimally verbal kids. So I don't call them nonverbal, we call them minimally verbal, because a lot of the kids have sounds in some words or scripts or whatever, but they're limited in their ability to functionally use language. And a lot of times these kids are very treatment experienced. Sometimes people call them treatment-resistant kids. So we have a project that we're doing now with treatments, trying to get kids talking and using augmentative systems and other kinds of things, and we're having great success with 5 to 8-year-old kids, because the goal, of course, is to get kids talking by the time they're 5, and about 30 to 40% are still not talking by the time they're 5. But I have a graduate student who, Kelly Kruger, I don't know if she's here, she's looking at the kids that we're seeing in the lab, and she's going out to the school just to see, well, what is their language environment? What are they doing at school? And it's pretty sad. It's pretty sad. So 41% of the time, and she's there for 2 hours, they're unengaged, 41% of the time. In fact, they're engaged only 18% of the time. Some kids, a lot less, 6 minutes out of 2 hours they're engaged. So when you're on break, more than you're engaged, you're not learning socially, you're not learning in terms of your academics, and I think, as Shafali said, I think more than half of our kids, our kids are smart. They're all savvy in really interesting ways. About half of our kids can read, but they're nonverbal, supposedly nonverbal. So I think we need to think about how we challenge those kids and how we make those environments so much richer. So that's kind of a new area for us as well. And next steps, just quickly, natural course of treatments, research to practice, already talked about this. Schools is where we need to be. We need to collaborate. We need to do a better job about getting our message out, what our research findings are telling us, and then working with community settings. We need to measure child outcomes that are meaningful and in natural environments. And we also need to publish what doesn't work. So we publish a lot of significant findings, but not everything is significant, and I think those are important findings as well. And our next steps are to deploy these interventions into the community so they can be sustained. And these are my collaborators, and I want to point out my school partners, Carolyn Gelfand and Debbie Moss from LAUSD, and Ellen Schneider and Sonia Dixon-Brax from Manhattan Beach Unified. And if you're interested in research, please call. Thank you.